Hello and good afternoon and welcome. It's a great honor to present for you here today in Lyon virtually. Thanks so much to Professor Lafont for this wonderful invitation. Bonjour tout le monde, c'est un grand plaisir de vous présenter et vous pouvez poser vos questions en français bien sûr. These are my disclosures. So I live here on the west coast of Canada on Vancouver Island, and I'm going to explain a journey how we came across a technique to change outcomes, what we believe is quite dramatically for patients with spasticity, and it really has its origins in French and Belgian technique. You can access everything that I've talked about, all the techniques in this journal, open access to ACRM, and I would encourage you to look there. So in spasticity, we talk about the vicious cycle, and it's been very well described by Jean-Michel Grassi and Lynn Turner-Stokes about tissue shortening, getting worse and worse, muscles get contracted, and spasticity can get worse. And while we absolutely know this, is it absolutely true? Because some patients who treat for spasticity and they respond incredibly well to intervention, and others don't. So does everyone always get a contracture? We're not quite sure. So I always thought I was pretty good at spasticity management. I went to all the congresses, I did lots of talks, I did early intervention, multidisciplinary rehab, but it wasn't until I met Thierry Deltome from Belgium that I realized everything I knew I had to start over. So Professor Deltome has a wonderful series of publications on using motor nerve branches to the tibial nerve branches of the leg to decide exactly which muscle in the leg is contributing to a spastic pattern. They can then treat it with botulinum toxin or a neurectomy or even tendon lengthening. And this blew me away. It was an approach that I had never heard in 2016. And we actually tried very much to do his techniques of motor nerve blocks. And we struggled with the technique just because of the difference in the technologies between the countries, the needle probes, the EMG machines. But we knew that he was the future and was brilliant, and he is now a good friend. So to understand how we're going to look at this today, so Professor Deltome really believes that you should use the modified Tardieu scale. So in your ABCs, it's B for better. So we know that V1 is the maximum range of motion you can achieve slowly. V3 is the quick catch. And then the patient has their active range of motion, which they care about. And in spasticity, we try to get to their V1, their maximum range, but we believe we can probably change the range of motion between V3 and V1. So you really need to understand these angles to continue. So here's a classic case of a localization that Professor Deltome would have taught me, how to localize the spastic toe claw, la griffe en français. And we know that it's more of a dystonia than even a spasticity. So you have to localize that nerve. It often does not respond well to localized injections in the muscle because of the spastic nature. But here we do a nerve block to the branch to the FDL, and he doesn't have a claw. It was when I came to France in 2017 to Versailles Congress that I realized that this type of nerve block was standard of care in France. And they've been writing about it for decades, but why didn't I know this? And I discovered that the French have all kinds of literature. Now, I happen to speak French, so it made it easier for me, but they had all kinds of books on how to do surgery and neurectomy. And my colleague, François Genet, wrote this beautiful paper on how to decide which was the most spastic muscle contributing to the flexed elbow pattern. And indeed, it was the brachialis branch, not the biceps, not the brachioradialis. So I was in France, and then I realized that I can do this. I saw fireworks. I saw music and light. It was very dramatic. It was overwhelming. I have a history of art background and dance. And seeing this inspiring scene in France, I realized I can take this knowledge home and we can figure out nerve blocks ourselves. But in Canada, I do lots of my spasticity management with ultrasound. So here we are doing a gastrocnemius branch injection. His soleus, which is the muscle underneath, is fine because when we bend the knee, he has no tone. And you can see his lateral branch is so tiny and atrophied. So in order to get into that fibrotic area, I have to have good localization. So I use ultrasound. I just never realized that I was looking at nerves all the time without knowing it. So when we came back from Versailles, we got a group of doctors together, physiatrists, anesthesiologists who could teach us nerve blocks, an ultrasound machine, physio, and orthotist, 4 patients, 2 hours to learn nerve blocks. So this was our very first attempt. You can beautifully see in the anesthesiologist's arm on the left, his trunk, his musculocutaneous nerve going down. You could always find the nerve by looking at the neurovascular bundle, big red, big blue, and a big yellow nerve. So it's always nearby. In contrast, on the right side of the screen, you will see the spastic chemodenervated arm that's had lots of botulinum toxin, and that arm, it's harder to find, but you can see it branching off. Of course, we're going to be using electrical stimulation to localize. And there's a great paper by Matsumoto, Muto, and Munin talking about how to localize for phenol blocks. So this was our very first attempt at a musculocutaneous nerve block. My colleague, she had never done this before. I had never done it before. She went first. She's putting her needle in. She can see her needle poke. The muscle is there very nicely. The blood vessel is pulsating. She's going to find the nerve. We did stimulate already, but this time she's just putting in the needle for the lidocaine, and it is going to cause a block. So this was the very first patient we did. You can see his V3, very classic, where he gets his first catch, and his slow maximum. He still has a degree of contracture at the end. It won't go further. If we continue to look at him after his nerve block, characteristically with a nerve block, you lose your V3. So he has no V3, he goes right to his V1, but that's it. Now, after we did 4 patients that day, my colleague Daniel Vincent, anesthesiologist, said, why don't we just do a cryoneurotomy? This is something I knew he did for 30 years, doing cryoneurotomy, which is freezing a nerve with a probe at minus 60 degrees, which causes a long sustained nerve block, mostly used in pain, but the machine actually has a motor setting. The thing about cryoneurotomy, which I learned, was that it doesn't cause neuritis or neuroma, unlike phenol or other techniques, because you actually preserve the lining, the epineurium and perineurium. So the technique of cryoneurotomy is essentially you introduce a very thin probe through the skin at minus 60 degrees, and gas forms an ice ball. That ice ball touches the nerve and causes the axon to break down through Wallerian degeneration in a length-dependent fashion. You, however, remain with a tube of the perineum and epineurium, and that tunnel can grow back over the next time depending on the length of the nerve. So millimeter per day, inch per month technique that we all know about in nerve damage, after it breaks down, it will regrow, and there's many studies from pain and rat studies showing that it will regrow quite nicely. So this still seemed quite incredible. So it's really, how could this little demonstration here of a ball of ice that we're going to freeze and some saline here to show you how quickly the ball will form at minus 60 degrees. And as soon as we turn off the gas, the ball will stop and you can pull it out through the skin. How could this possibly treat for spasticity? It seemed preposterous. I mean, look at the size of it. So I did a literature review, and lo and behold, there was an obturator nerve case study in 1998. Much later, we found a beautiful abstract from Patel and Paulin, where they actually described this exact technique in the musculocutaneous nerve, but they did not publish. And there's many rat studies showing motor. Now, Dr. Vincent has done thousands of these cases, and Dr. Andrea Trescott, who was the pioneer, basically talked about if you could accurately target, you can do this. So here we go. So if you recall our first patient, he did very well with his nerve block. This is the same gentleman with less tan. 9 days after his cryoneurotomy, he has no contracture, full range of motion. In fact, he hadn't tried to use the arm because he is a hemiplegic man. He doesn't use the arm, but he actually discovered that he had some active range of motion. And if you look there, his active range of motion now approximates his V1. And you can see the difference here. So he gained over 30 degrees extra range of motion in the arm, and his Ashworth was much better. At 2.5 months, rather than getting worse, it's actually getting better. So in this case, I decided to put some botulinum toxin in the brachioradialis to give him a boost in the finger flexors, and he's getting better. He continues to get better at 6 months. His arm is very strong. He can lift his arm. And Professor Dehome has shown us that after an neurectomy, if you do it partially, it will regrow back with good strength and less spasticity. So at 1 year, he is still doing great. So this is him at 26 months. He has not had tox in a long time because of COVID. He is very loose. He can open the arm on his own. It's actually improved with time. And I want to know how much strength he has. So I gave him a dare. I said, can you pull me? So I'm going to grab his arm. He's going to give me some resistance. I'm on a rolling chair, and boom, he's got strength. So you can see if we look at his V1 and V3, it improves over time from 142 to 180 degrees in his V1, and his active range of motion went from 72 degrees to 166. This was our second case, also seen the first day. She improved after her cryoneurotomy to the musculocutaneous nerve, but I was not happy enough. You can see after her cryoneurotomy, much better range of motion, but there's still a spastic catch. And I felt that this was most likely due to her brachioradialis. So I did a lidocaine block, and look how much looser she is. So we went on to do a brachioradialis cryoneurotomy. You can see how well it's maintained, and everything is better. This is the localization along the triceps. And at 26 months, again, she's not had injections for some time, though I did continue her botulinum toxin. She's much looser, and she's pleased. It's less stiff, it hangs, and she sleeps better. Here's yet another patient. You can see the difference with a lidocaine nerve block. After the procedure, though, she has quite a bit of clonus getting in the way of her range of motion. So we do a cryoneurotomy. Within 1 month, it's kicked in. She's significantly better. And then we see actively, though, her clonus is still there. So we didn't do anything to the clonus, but I want to know why. At 3 months, look how loose she is. Much better, but she has clonus. So we do a closer assessment, and we see it's actually coming from the finger and wrist flexors. So we do a median nerve block under ultrasound guidance. The hand becomes loose, no clonus. So you can see that she maintains her looseness. And at the same time, after I did her botulinum toxin to her finger and wrist flexors, it's nice and loose, and she has no clonus. So synergistically, this is working well. And at 18 months, it's even better. So we're seeing cryoneurotomy improving over time rather than getting worse. Here's yet another elbow. You can see how stiff she is, whereas after the nerve block, she opens quite nicely. I'm going to do several passive range of motion for her V1 on the right. And the last one, if we look right now, she's going to do that actively. So very nice. And then we can do a musculocutaneous and median nerve block to see what her function is, super loose. And she has a tight-fisted hand, so I actually want to see what the contribution of the median nerve is. I can now open her fingers so she does not have contracture, and she can supinate. So with a cryoneurotomy, we have an immediate partial effect. Within 5 minutes of the procedure, I can open her arm much better. This is actually Dr. Vincent, who does our cryoneurotomies right now. He's the anesthesiologist. Much better at 6 weeks, you can see. And we figure maybe do some brachioradialis and triceps toxin to make it easier. Now, on the left side, you can see that she was still a little bit tight, so I did a radial nerve block, much looser. But after we did the median nerve block, my surgeon decided to do a microfascicular dissection and did a dissection to her pronator teres, flexor carpi radialis, and flexor digitorum superficialis, because with cryoneurotomy, we cannot selectively work to those nerve branches. Here's yet another patient, before and after cryo. You can see his improvement. And this woman had not much of an improvement after just the MSCN nerve block, so we actually added in a radial as well. And then Dr. Vincent did both cryoneurotomies at the same time. She has no active movement in this arm. This is all about comfort and positioning. It's a paralyzed arm, so she's better at 1 month. But then again, I saw her 7.5 months after the cryo, and you can see how much looser it hangs. So Professor Del Tome has written all the texts on how to do these. Alessandro Pacelli has written a very nice paper on ultrasound guidance recently. I am going into the trunk of the nerve here, and I can stimulate all the muscles, gastrux, soleus, tib post, and flexor digitorum longus here. And you can see here, if I want to be more selective, I can just do the gastrux lateral branch, and then I can distribute my lidocaine, I can pull back, and then I can go to just the medial branch if I want to do those and spare the other substances. So with ultrasound guidance, we can really control our nerve blocks and plan our cryoneurotomy treatment. These are wonderful landmarks I've taken from Del Tome and Pacelli. You can watch this presentation later to see. And Professor Del Tome has written all of these landmarks out. And with a combination of a French atlas book, we have made this guide for our clinic. Again, you can always come back and pause to see it. This was our first patient. She is pregnant. She has great difficulty progressing her foot because of equinus deformity. She cannot wear her ankle foot orthosis because of the weight gain. And right after either the nerve block or the cryoneurotomy, you can see that she now has a step-through gait. She's walking much better. 4 weeks after the cryoneurotomy, she is now over 8 months pregnant. It's safe because it's just an ice. She has weakness in the foot, but she can walk better. And then, of course, we follow her up 10 months later. She's actually overcorrected by her AFO. It needs to be adjusted. And her gait has improved. Look how nicely she's walking. There's still improvements to be made, but she has 3 kids. She's happy for now. This was another gentleman with a significant equinovarus deformity. You can see really inverts as well. 5 minutes after cryo, he's trying to figure out how to walk because suddenly he can progress at the ankle. And then he sent me this video recently, walking in the hall at home. You can see he can actually do a step-through gait. He has sufficient tibial progression. Again, not perfect, but he will need some physiotherapy, perhaps some more botulinum toxin, and we will redistribute. This would be that spastic toe claw that Professor Deltome calls a dystonia, la griffe, and you can see that he has that toe claw. We do the diagnostic nerve block, and again, you can see here that he doesn't have the toe claw. He can extend his toes. We are able to isolate that branch with cryoneurotomy. Very difficult to do surgically because it's small, but we were able to stimulate and freeze. It is significantly improved. His gait speed is better, and if we look at it in slow motion as he steps through, you will see him lift up his foot. He does not have that terrible claw, just a slight amount, but look how his toes actually extend at the end and come back down. It's quite exciting. We can do a pectoral procedure as well. Here am I localizing the pectoral nerve. I will stimulate, and then we will do a cryoneurotomy after a nerve block. So this was a very spastic quadriplegic gentleman with high-dose baclofen and medications. We were very much easily able to reduce his tone with a nerve block, and this was on both sides. So 9 days after his bilateral pectoral cryo, for the first time since his spinal cord injury, we were easily able to lift his arms above head, and it has remained. For him, it's quite exciting because he had an axillary nerve transfer by our plastic surgeon who does our spasticity procedures, so he is able to externally rotate enough to use his triceps. We like to put these techniques together. He had very little hand opening, so I did an ulnar nerve block at Guillen's canal, seeing that he can actually open his fingers if I disengage the interossei. I put on a TENS machine to let him try to work on some electrical stim, which made it better. So then what we do is we add in, he did very well with interossei toxin. This was a pediatric case, very stiff, very painful in the arm. We did the cryoneurotomy to both sides. Again, Dr. Vincent did the procedure. His mom said that his positioning is much better. He expresses less pain, and getting in and out of the bath and dressing is so much easier. We can also just do a median nerve block. Now, I mentioned to you before, this is a mixed nerve. So you're going to take out the median branch and the sensory branch, but we very much use it for diagnostics to see which finger flexors we might want to release with surgery. But this gentleman, who went on to have a lidocaine block of his brachialis, he loved it so much, you can see him standing before and after. He went on to have a MSCN cryo, and he begged us to do his median nerve. So we did several nerve blocks, and he actually had no sensory disturbance. He said, I don't feel my hand anyway, so how can that change? And we realized when we did the block, he has no active function in that hand. So because he has no active function, we didn't need to do a fascicular block. We could just freeze the whole nerve. So now he can easily open the fingers. They rest more comfortable. He has no sensory disturbance. And I was able to see him again. The cryoneurotomy is holding. It's still a little bit tight in this picture, but the next follow-up, you can see his dad is doing it for me because of COVID. He's nice and relaxed, and the fingers are actually opening on their own. Our patients that have active finger movement, we do a microfascicular neurectomy instead. So just to summarize, we want to make sure that we choose nerves that are mostly motor, so musculocutaneous to brachialis, or biceps, radial to brachioradialis. We can do any of the tibial nerve branches to the gastrocnemius, soleus, tibialis posterior. We can do the obturator to the adductors, the pectoral nerve, and the femoral nerve can be done as well for a very extended leg. We've just targeted this in patients who don't ambulate at this point, but we might do it selectively to ambulators. So Dr. Vincent uses the Lloyd Neurostat 2000 cryoneurotomy machine. With you can either have machines with CO2 or N2O. This is the machine. It's quite old. There is a small portable one that's now on the market in our country, which we're going to hopefully try to get. This machine is no longer made in Canada, so we are trying to import from the United States a newer version through a research protocol. If you have a machine, many countries have them, you can start right away. This is what the probe looks like to generate. This is what the catheter looks like. We put it through a 16-gauge catheter into the skin. and you can see it very, very nicely on ultrasound. Now remember, unlike phenol, you really have to be touching the nerve to make the cryoneurotomy. You have to put it in and electrically stimulate, and this is exactly how Dr. Vincent stimulates. He puts the probe through the skin. You have to touch the nerve for about 4 minutes. So if someone has a lot of spasticity and clonus, we have to put them in a position where they're not moving. Absolutely essential is low stimulation threshold for nerve blocks and cryoneurotomy. You want to be at 0.8 milliamps or lower. If you do something like a clavis or a myoguide, you will stimulate the muscle fibers and think you're on the nerve and not. So you must touch the nerve. This is why we cannot do this procedure without ultrasound guidance. So this is how Dr. Vincent sets up his room. He has the cryoneurotomy machine, he has the ultrasound, and he can target any nerve he wants. So I'm going to summarize my talk. I've done a lot of speaking today, a lot of cases. I would recommend that you watch this again if you're interested. Dr. Vincent, remember, taught us how to do nerve blocks in a 2-hour afternoon. We have a weekly nerve block clinic, and we are really excited, our plastic surgeon and cryoneurotomy, how we can change outcomes. So again, large nerves, we generally do cryoneurotomy. For very fine nerves, such as the hands, we will do a microfascicular neurectomy, all based on the long-standing French tradition of nerve blocks. So thank you so much, and I welcome you to answer questions. C'était un plaisir de vous présenter aujourd'hui.